right, so Mr. Williams is gonna have a right shoulder arthroscopy today, so I'm going to do an interscalene block for him. So before I go into the room, I just look through his history, make sure he doesn't have any absolute contraindications. That would be obviously refusing the block, but also if he had an infection at the site, he had coagulopathies. Some relative contraindications would be obviously if he was a child, too young to cooperate, if he had allergies to the local anesthetics, possibly COPD, or if he had a second or third degree block. Those might preclude him from having this block. So I don't see any of that in his chart, so I'll come in and, sir, can you tell me your name? So I'll just identify my patient first off. And so what is the plan today? I heard you're gonna have a shoulder surgery, is that correct? And which shoulder is that? So we'll confirm it is the right, and while I'm in here, I'll initial his right shoulder. So with this block, some of the reasons we'd like to do it is it can give you a lot of pain relief during the procedure and afterwards as well, allow you to start physical therapy a lot sooner and take less narcotic pain medications. There are some risks with it, however. One of the big ones is obviously bleeding, because it is poking in your neck, but we do take precautions, and I use an ultrasound machine. There's also a risk of infection, a risk of nerve injury. There's also, if it did numb, it's very close to the nerve that controls your diaphragm. It's called your phrenic nerve. If we numbed that, you could have some difficulty breathing on that side, but again, it's a temporary thing that goes away. There's also some side effects that can, happen fairly often with this block. On that same side of your face, you can have some nasal congestion, your pupils can be unequal, you can have some weakness of that eyelid, and just some general facial weakness, kind of a dry mouth on that side as well. That does go away when it wears off, but it is something that you could have. So obviously an alternative to this is we could just not do the block, and we could do it just with oral medications or IV medications for pain management after your procedure. Would you like to proceed with this? Okay, so I'll have him sign a consent. Then next, going back, I'm gonna do this after induction. So again, we've already confirmed his site and all of that. So if he had been awake, I would put on a pulse ox, blood pressure, all of that, some supplemental oxygen, and consider giving him like 2 milligrams of Versed and possibly some fentanyl to get him more comfortable just beforehand. But again, this will all be post-induction, so he'll already have all of those monitors and be ventilated. So assuming we're back there, we'll go ahead and position him. He'll be supine with his head turned to the left. He could potentially have his head up a little bit, just kind of depending on what I needed to visualize that. So first off, I'm going to take a look with my ultrasound. I'm going to be using an ultrasound and a nerve stimulator. And then I already have all of my other equipment ready in the room. So I'll go ahead and looking at his ultrasound here, I'd start right at the clavicle. So just general landmarks that I'm looking at, I would expect it to be across from about C6 or the cricoid cartilage in between the sternal branch of the sternocleidomastoid and the clavicular branch. But again, I'm going to use my ultrasound just to identify that. So I'll start down at the clavicle and I would sweep up. So just looking at the ultrasound here, what I'd be looking for is the sternocleidomastoid kind of on the top here. To the right would be the middle scalene muscle, and to the left, more medial, would be his anterior scalene muscle. In between those, I should see a stoplight appearance of C5, C6, and C7 nerves. So again, I would just scan up until I had a good view of that. At that point, I could go ahead and just roughly mark where that ultrasound probe was so I can find it and put the drape on appropriately. So at this point, I can go ahead and set this to the side, and I'll get my kit all open. So I do have some chlorhexidine, so I can go ahead and clean that site. So I clean for about 2 minutes, scrub, make sure I get all the way around and back up. And I want to let that go ahead and dry fully, so it'll probably take about 2 minutes or so. I'll just make sure I have my kit open here. And I go ahead and put on my sterile gloves. go ahead, now that he's nice and dry, it's been at least 2 minutes, I'm gonna go ahead and drape him. So I peel this off, drop this right over that site, and open that drape up. So he is asleep, so I wouldn't strictly need to numb him up, but I am gonna go ahead and just use some 1% lidocaine, draw up about 3 cc's, and I'll have that ready to put a skin wheel in at the site just to keep him nice and comfortable. So again, go ahead and draw up that 1% lidocaine, and I could use a 25 gauge needle. While I'm here, I'm also going to make sure that I have my needle all set up. I've got a 22 gauge here, and it has a connection for my local anesthetic and also for the nerve stimulator. So I'll just set that out where it's nice and handy. And, all right. So I do have my probe cover, sterile probe cover, and sterile gel for this, so I can put a little bit on that site right now, and if I wanted, I could put a little bit inside my probe cover as well. So I'll have you drop that in. Obviously, we would have a nice fresh one in real practice, so we'll say that this smoothly slid down. If you don't mind just grabbing the end. And again, if I wanted, I could put a little more, just a little more of the gel, sterile gel on the end here. So at this point, I come back and just reconfirm my landmarks, make sure I've got it starting again at the clavicle and coming back up. And again, I'd be looking to see my sternocleidomastoid on the top, my anterior scalene muscle and medial scalene muscle here on the more lateral side. And again, identifying C5, C6, and C7, that stoplight pattern. Okay. So once I've identified that, I know that I'm gonna go ahead and put just a little skin wheel here, but I'm gonna palpate the artery just to make sure I don't get too close to it when I go ahead and put that skin wheel in. So while I'm palpating the artery, I'll go in to do the skin wheel, aspirate, just make sure I'm not too deep, and put a nice little skin wheel in and let that start to numb up. While that's numbing up, I'll go ahead, I just bring it back, re-identify my landmarks, and at this point I go ahead and get my needle out. Again, that's like a 22 gauge needle. It's 2 to 3 centimeters long. And if you don't mind, I'll have you, so I already drew up about 40 mLs of local anesthetic. What we would use would depend on the facility. There's many different things, but for this case, we'd say it's, let's say 0.25% marquine, and it has 4 milligrams of dexamethasone in it. So we'll go ahead and flush the line with a little bit of that, just so we don't have any air in that line. And then we have it hooked up to the nerve stimulator as well. So now that that area should be nice and numbed up, and I've re-identified my landmarks, and again, this sterile tubing, we go ahead and come in. I'm coming in plane, nice and lateral, just right along the edge. And I'll be watching the ultrasound as I advance it. So for this, it's anywhere between like 1.5 to 2 millimeters in is what I'd be anticipating, or the depth on this. So I should be seeing it. Again, I'm coming from the lateral. I'd see it come through the middle scalene muscle down, and I would start probably below C7 there. Obviously not letting go of the needle, but that's just for demonstration of what I should see. So again, once I saw that it was nice and close to the nerve, I'd have my assistant turn on the nerve stimulator. And we could start at just like 0.3. 0.3. Okay. So at that point, since I can see that I'm that close to the nerve, I should see a twitch, either in the deltoid, the bicep, the forearm, somewhere in that area. If I didn't, I would know that I need to advance a little bit closer. So now I'm gonna have you turn it down to 0.2.
0.24, 0.20.
Okay. And at this point, I should have lost that twitch. So I'll have you turn it back up to 0.3. If I hadn't, I would know I was too far into the nerve. I need to back up a little bit.
We're at 0.3.
So at 0.3, I've reestablished the twitch. So I'm gonna have you aspirate. Just make sure that we're not in a vein. And we don't see any blood return. So I'm gonna have you give just 1 ml of that local anesthetic.
1 ml is in.
Okay. So this should ablate the twitch. So once it's ablated, I know that I am in the appropriate area. So again, I'll be watching the ultrasound to guide how much fluid I give, but I'll start giving it, we'll give it in 3 to 5 ml amounts, aspirate, give 3 to 5 mLs, and I'll be watching the ultrasound and watching it hydrodissect around those nerves. I can reposition it and make sure I get it nicely around C5, C6, and C7. And again, for a drug, it would really depend on what facility we're at, but we'll say for this purpose, again, it was 0.25% marcaine with 4 milligrams of dexamethasone mixed in. So total volume could be anywhere between 20 up to like 30 or so. It really depends on the individual. But again, I would use the ultrasound to guide that. So once that total volume is done, I'll go ahead and take that needle out. And we could take everything down. So because this is post-induction, I will have to reassess the quality of the block post-operatively. So we do that in PACU and make sure it was nice and comfortable.